Omicron's very emergence is another reminder that although many of us might think we're done with COVID-19, it's not done with us.
The Director General of the World Health Organization warns the new coronavirus variant poses a very high global risk. Hello, I'm Anand Naidu, and this is The Heat. Scientists still know very little about the new coronavirus variant called Omicron, but are sounding the alarm around the world. Experts now say the new COVID-19 variant was already in Europe before it was detected by scientists in South Africa. Cases have been identified in over 20 countries, including Australia, the United Kingdom and the Netherlands, raising fears governments will be forced to close borders and revisit restrictions. The United States plans to toughen coronavirus testing and screening of international flyers, requiring a negative test result within 24 hours of departure. Right now, the scientific community has more questions than answers.
We don't yet know whether Omicron is associated with more transmission, more severe disease, more risk of reinfections, or more risk of evading vaccines. Scientists at WHO and around the world are working urgently to answer these questions.
For more now on the Omicron variant, let's bring in our panel. Joining us from New York is Hilary Brick. She's a health correspondent for Insider. From Arizona, Will Humble is the executive director for the Arizona Public Health Association. Dr. Chris Smith is a consulting virologist at the University of Cambridge and co-presenter of the Naked Scientists podcast in the United Kingdom. And Dr. Angelique Coetzee is the chair of the South African Medical Association and a general practitioner. She joins us from Pretoria in South Africa. Thanks, everyone, for being with us. Dr. Angelique Coetzee in South Africa. Let me start with you. The Omicron variant was found in South Africa just over a week ago. What have you seen in terms of the impact it's had on people who have been infected with this particular variant? Are they showing any symptoms, or is it a bit too early to say?
Good evening from South Africa side. A very interesting question. Remember, I'm not a scientist. I'm a general practitioner at coalface with 33 years of experience. We just passed our third wave, and we were for at least 8 to 10 weeks. We had a bit of a breather, and now it's gone again. So I actually clinically detected that there was a new or a different clinical picture on the 18th of November, when I saw early that morning my first patient, young man, 29 years of age, and the complaints he gave to me was very suggestive of a viral infection. But the explanation that he thought was the reason why he felt the way that he didn't make any sense to me. Again, he's young, he doesn't really come and visit the surgery that often. So I decided to test him, and he was positive. So was the rest of his family. And that day, I saw 7 new patients with more or less the same clinical symptoms. And that symptoms was different from the Delta variant. I alerted the advisory committee on vaccines because I'm part of them, and I actually thought it was a research from the Beta variant, as the symptoms were very similar to Beta for me at that stage. Never thought it would be a new variant, and also simultaneously in the background, Lancet Laboratories also on PCR tests, one of the lab technicians also saw a abnormal type of PCR testing that didn't fit in. They also alerted, and then Prof. De Oliveira and his team and Prof. Salim Karim last week then confirmed that it is indeed a new variant. So while the science behind it is still being worked out and no one knows, and everyone is wondering, is it going to be fast spreading, is it going to be more deadlier, is it going to be affected by vaccines? What's the picture? The virus is still carrying on. It doesn't wait for the scientists.
Right now, Dr. Coetzee, very shortly after this variant was detected in South Africa, European countries imposed travel restrictions on South Africa, and that was followed very quickly by the United States. This has caused a certain level of frustration in South Africa, even anger. The South African president, Cyril Ramaphosa, said that these measures were, in his words, unjustified. You yourself said that it's a storm in a teacup. So what do you make of these restrictions? I mean, is South Africa being punished here for being open, for being transparent?
It's a difficult question. It depends on, where you stand. If you stand in outside of South Africa, you will say, no, we're not punishing you. We're just protecting our people. If you stand in my shoes, in my country, you'll say, why? Wait a minute. What is going on here? There's better ways to handle this situation than just closing borders for South Africans. That unfortunately also affect a lot of people. It's not just so easy to say, well, we close our borders. And I did mention before that I'm quite sure that this variant is already in a lot of European countries, but because of the symptoms, it's not been picked up. And people will think this is a normal cold and flu type of a normal respiratory tract infection, whatever they perceive it to be, without realizing it's actually a new variant. Which is quite fast spreading. And remember, you guys got quite a high number of cases on a daily basis. And everyone is looking for the severely ill. Everyone is looking for the Delta symptoms. And this symptoms is definitely not the same than Delta.
Right. Chris Smith, there's quite a debate going on right now on the effectiveness of travel bans. I mean, what's your view on this? Do travel bans work? Because as we just heard, this variant was thought to have been found actually in Europe before it was detected in South Africa.
Well, first of all, I want to salute Angelique and the rest of the South African team for spotting this, and not just spotting it, diagnosing it very promptly, and then sharing the data so that the rest of the world could then understand the threat. And it was a brilliant piece of work and a brilliant clinical spot, so very well done. I think I agree with Cyril Ramaphosa when he said that this really is unjustified, because the point he was making was in the same way that other variants were initially spotted in one particular geography, and then we closed down half the world, but it was basically shutting the door after the horse had bolted, because by the time we had enough cases to detect in one geography, there'd already been such huge dissemination internationally over various travel conduits and so on, that it was probably too late. But why I think it matters that we're talking about this is that this may turn into a storm in a teacup. It probably, in my view, will be. I think it's probably a more trivial manifestation of this infection. I don't think long-term it's going to be a major, major problem. I don't. And I think the vaccines will continue to defend us very well. But what it does do is to remind politicians that the problem hasn't gone away, that we do need to remain vigilant, and we do need plans in place, but we also need to make proportionate responses when we detect these things, because every time we get a variant in future, are we going to shut half the world? No, we possibly cannot do that. And so we do really need an opportunity to work out what does and what doesn't work and implement sensible strategies. But the number one sensible strategy, apart from getting a vaccine, is to do what the South Africans did, which was remain very, very vigilant. And the minute they spot something like this, to share that information so everyone can bring the collective think to the table and work out whether or not this really does pose a threat.
Right, Chris, in Britain itself, the Prime Minister Boris Johnson is now saying that people need to get booster shots. Let's listen to what he had to say.
We haven't ruled out anything. I've got to tell you. I think another lockdown of the kind that we've had before is extremely unlikely. I'll be upfront with you about that. But we keep everything under constant review. In our fight against the Delta variant, we think that it's basically been going our way, or going the way that we planned. So you're seeing, although cases remain high or high-ish, you're seeing a decline in the numbers of admissions to hospital and a decline in the number of deaths.
So, Chris, booster shots, but for now, no lockdowns. What do you make of that strategy?
Well, what the UK government and other governments around the world have done is effectively put in place some sensible strategies that will actually help fight the major challenge, which is not this new variant emerging from the southern part of Africa and now manifest everywhere. It's Delta, because in the UK we've got probably 40, 50,000 cases a day that we know about going through the country, you can probably comfortably double, possibly even triple that number, because actually most of the cases are not presenting with symptoms anymore, including in much older people. But we are still seeing, nevertheless, that translating into people ending up in hospital and some severe consequences in a small minority of people. I emphasize small minority because when we had 50,000 cases per day in the pre-vaccine era, we were seeing tens of thousands of people losing lives and ending up in hospital. Half of our entire national bed stock in our National Health Service had coronavirus patients in it. We had hundreds of patients in the hospital that I work in. That is not the case now, thanks to vaccination. So that I think the number one thing is we have to stay one step ahead. We have to protect people. And the thing we need to protect them against at the moment really is Delta. And all of the measures that are being put in place as an off chance, let's just do this as a precautionary measure against this new variant, will actually work very well also to keep Delta at bay over what is the most parlous period for most countries in the Northern Hemisphere right now. It is winter. These sorts of things do spread better in winter. This will help against Delta, but it will also help a bit, if we need it to, against this new emerging variant.
Will Humble, there is, of course, understandably, deep concern here in the United States over this new variant as well. That variant, the Omicron variant, has not been detected here in the United States yet, but scientists are telling us, look, it's inevitable. We will see this soon in the country. President Biden is also calling for booster shots. What do you make of the measures that the U.S. is taking?
Well, I agree with the initiative on the booster shots, but I really disagree with the travel restriction. And the previous guest hit it right on the head. You know, travel restrictions like President Biden implemented have no long-term benefit, really no midterm benefit, and a very marginal short-term benefit. Maybe it buys you a week or two. I would much prefer world leaders to be focusing on redoubling their efforts to donate to COVAX through financial means, by policy changes, by donating vaccine. That's an appropriate response for world leaders, is to say, you know what? International global vaccine equity is the real problem here. And the longer this virus circulates in the developing world, the more opportunities there will be to create new variants. And the answer to that is to improve international vaccine equity, which is absolutely atrocious at this point. The vaccine rates in Africa are, in many countries, below 3%, much higher in South Africa. But the focus on travel restrictions, in my opinion, is counterproductive when they could be focusing on a summit to really improve the resources into COVAX.
Hillary, let's talk about these travel restrictions that the Biden administration wants to impose. It will reduce the time, as we've just been reporting, that time window for tests for travelers coming into the United States. It'll be reduced from 3 days, which is what exists right now, to 1 day. Will that work, and is that practical? I mean, it's going to be very expensive for travelers because they need to get that result done, or the test done, and have the result in hand within 24 hours.
Right, yeah. So this is a measure that the CDC is considering right now. It's not definitely on the books yet, but it looks like it's probably going to be coming in the next few days. President Biden is tomorrow going to announce like a winter plan for COVID, so it might come then, or we don't really know yet. But basically, yeah, this would require, you know, in addition to being fully vaccinated, you also need a test within 24 hours. And my guess is the logic there is that, you know, with variants like Delta, which we know are more transmissible, you know, it's best to have really accurate, you know, up-to-date information, because, you know, a test 3 days ago might not tell you very well who has COVID right now. So I think that's the logic there, but it is obviously going to be, as you said, a challenge to implement and to be able to get a test back in 24 hours.
Hillary, one other measure that's already been put in place, and that is the CDC has introduced expanded surveillance at several airports, JFK in New York, San Francisco, Newark in New Jersey, as well as in Atlanta. What can you tell us about these measures?
Yeah, so this is being done in conjunction with a private company, and basically they're doing screening of flights coming into the U.S. I think largely they're focused right now on flights coming from Africa, and then also like Africa to Europe and then to the U.S. And basically, so they'll do the testing is all free, but it's two types. One is they'll do pooled testing of the passengers coming off the plane, so they'll test a few and put them all together and then see if that test comes back positive as an indication of like whether the virus was on that plane. And then of course they'll do home testing. So send people home with a home testing kit they can do 3 to 5 days later. So different types of surveillance there.
Dr. Kutsia, across the continent of Africa, there is about 10% of adults have been vaccinated so far. That's very low. What is the situation in South Africa?
In South Africa, currently, above the age of 60, more than 65% of people have been vaccinated. Those that got their Pfizer, fully vaccinated with Pfizer, are now eligible for a booster shot on Pfizer. And then the rest, in total, the adults being vaccinated is just over the 40% in the country. So yes, we would like to have much higher numbers of overall people, but for now, your vulnerability group is normally your age group 60 pluses. So we'll see how it play out going forward. I did see quite a few breakthrough infections, especially on, well, we only have Pfizer and Johnson & Johnson on Pfizer, but I need to stress for now that these breakthrough infections is quite mild. And what is a good sign to me is the fact that some of these people are above the age of 80 that I have now starting to see, vaccinated and very, very mild disease.
And Dr. Kutsia, what about vaccine availability in South Africa? Does the country have enough? And what about distribution, the logistics behind that?
We have more than enough vaccines currently. Our government actually asked the Johnson & Johnson and Pfizer to please hold back on some of the new assignments that were supposed to come in, because we have enough. It is to get the people, and I think this is a problem in all the countries, to get people that is hesitant to go and get themselves vaccinated. One of my, fears is that people will use the fact that vaccinated people people will use the fact that if you are vaccinated, you get the COVID-19 mild, that's the reason why they don't want to go and vaccinate, because it's not going to protect them, which is not true. So it's to get the right message out there and to tell people, please go and get vaccinated. But again, you can vaccinate your whole country as much as you want to. I'm always saying if Africa is not being vaccinated, no one can sleep safely at night.
Chris, you said something which caught our attention. You said that if the Omicron variant replaces Delta and with its milder effects, then it could be a blessing in disguise. Explain that to us.
I don't think I can be credited with being the first person to say this. I was asked to comment on this to somebody recently. And it's a tantalizing hypothesis, isn't it, that this thing could displace the existing circulating variants. And if it turns out to be far more trivial in terms of its clinical manifestation and impact, then actually we would be robbing Peter to pay Paul much more handsomely. So what do I mean by that? Well, if we've got a variant of the coronavirus which turns out to be much milder, but nevertheless leaves in its wake a population who, having caught it, are now immune to it, it means that then you push to the margins other viruses and other variants that you're now immune to. You rob those variants of people to infect, so it basically fizzles out. And what does remain in circulation is this more transmissible, but at the same time less pathological, so in other words, nicer to us, form of the virus. Now, that's a tantalizing speculative hypothesis. It would rely on this new variant that we're discussing today being more infectious and more transmissible to a significant degree than the other circulating variants, so it would outcompete them like two cars in a race where one's got a bigger engine. We don't know that's the case, because at the moment the data we have from Southern Africa is based on that particular geography, that particular demography, and that particular rate of vaccination. Other countries, the UK where I am, for example, have a very different population structure, a very different vaccination rate, particularly across age divides, and these factors will almost inevitably play a really important role in how these variants, new and old, compete and spread. So really the only thing to do here is A, reassure ourselves what threat this might pose, and those experiments are going on at the moment, and then do good old-fashioned epidemiology, following up the numbers to see what the dynamics look like and whether this thing does look like it's more transmissible and leaves people immune in its wake or not.
Right. So, Chris, what kind of timeline are we looking at to get a clearer picture of how dangerous Omicron is, or perhaps benign, relatively speaking?
There are short-term and there are long-term things that we must do. In the short term, the first thing is making the clinical observation, which the South African doctors and scientists did. Then there's the genetic tests, which they've also done and shared with everybody genetic code. And when you get these genetic codes, we line up the new variant with the existing variants and we ask, are they different? And if so, where are they different and how different? And what bits of the genetic code are different? And then you ask, well, if there are differences in a certain part of the genetic code, what job does that part of the genetic code do in the virus? And in this case, the reason scientists were a bit alarmed is because there are a lot of changes, 30 different genetic changes, in the part of the virus genetic code that it uses to build its outer coat, and specifically the spike that sticks out from that outer coat. There are lots of those spikes, and they help the virus get into our cells. And also, critically, those structures are used by the vaccines to produce antibodies against that structure to defend us once we've been vaccinated. So, if that structure changes demonstrably, the virus may change its behavior, it may become more transmissible, it may become more infectious, but it may also be able to swerve around the protection afforded by our vaccines. So that immediately sets up the question, right, if we take antibodies made by people who've been vaccinated with the present generation of vaccines and we mix them up with this new variant in a test tube in the lab, does it stop it growing? And if it does stop it growing, how much of that antibody do we need? And once we know that, we then say, well, how much of or what proportion of the population have antibodies of that sort of level? And if the answer is everybody, or quite a few, especially if we give them a booster, we're home and dry. If the answer is lower than that, we're not. And that's when we go embarking on perhaps engineering our vaccines further, giving more boosters and vaccines. And at the same time, what we're doing is monitoring the population to see how this thing is actually evolving, changing, and interacting with the population. Is it producing lots of cases? Is it spreading alarmingly? Or is it just indolently bumbling along? And if so, it will probably fizzle out.
Will Hummel, looking at some of the measures that are being taken around the United States, New York has just issued advisories recommending a return to wearing masks indoors. What is the situation like in Arizona, where you are?
Well, as you mentioned, we have 50 different experiments, 50 different states. The measures, I was just in New York last week, and the measures there are terrific. You've got, to go to a restaurant or to a museum, you have to show your vaccination card. There's indoor masking everywhere you go. There's, people are paying attention to distancing and so forth. You come out to Arizona and we have none of those things. Our governor is opposed to any kind of mask mandates at all, including in classrooms. He's actually got executive orders prohibiting, using vaccine requirements for admission to areas. State employees are not required to be vaccinated. There's prohibitions. And so, we have 50 different approaches in Arizona, which has been a problem throughout this entire pandemic, where we've got governors that are actually in control of most of the policies that affect transmission of this virus. And so that's one of the reasons why we've had such a disjointed response in the U.S. is governors have more authority than our president. And in our state, in Arizona, our governor is very much laissez-faire and has really no interest at all in mitigation measures to slow the spread of this virus. And so as a result, we're at levels that we saw back in February, actually. And as much as 30% of our hospital capacity in Arizona is now taken up by COVID patients, almost all of them persons that have chosen not to get vaccinated.
Hillary, we are still learning a lot about this new variant, but the CEO of Moderna, the pharmaceutical company, was quoted as saying the existing vaccines may be significantly, he said, less effective against Omicron. Is there any evidence that tells us that that might be the case?
It's really difficult to say at this point. I think we heard Chris explaining it really well a little earlier, but obviously because it does have so many mutations, and just, the volume of mutations on it is so huge that it's kind of where that speculation comes from. But again, it's going to take probably at least another 10, 12 days to really get a good sense of how the vaccines interact with Omicron. And I think most scientists feel somewhat confident that the vaccines will have some power against Omicron. The question is just, like Chris was saying, what level of antibody is best, and what else needs to be in place.
Dr. Coetzee, the WHO is calling for a new agreement on pandemics and how they're reported, given what we've seen after South Africa reported this variant. What would you like to see?
Well, that's a very good question, and I think it's a step in the right direction. I think what we need to do is to have to agree on transparency, to agree on how can we mitigate what is if there's a new variant coming up? How do you mitigate that? How do you communicate between countries? And what would be the first steps to take going forward between the countries? And should we not share more information, especially around the clinical pictures? What I've seen is everyone is so hospital focused and focus on the severe disease, which is important because the severe disease is putting a strain on the healthcare systems. But in that process, people are forgetting the primary healthcare level and what is happening there. So if one look at new regulations coming up, I think we need to bring in clinical pictures in tertiary care as well as in primary care. And again, how do we bring it out to other countries, and how do we share that information that is out there without being penalized or without being making that specific country to be the villain of the whole circus that's going on. It should not be like that.
Right.
And again, transparency is, for me, transparency and openness is extremely important.
Right. Chris, one final point, and we've got just less than a minute left. There's a new class of antiviral drugs that we're hearing about right now. In fact, Merck's COVID pill for high-risk adults is one of those drugs. Pfizer has also got a new drug on the cards. What can you tell us about these new drugs?
Well, one drug, molnupiravir, which is a Merck drug, is a new drug in the sense that it's being used in a new way. The other drug, which is Paxlovid, which is Pfizer's drug, is a brand new drug dedicated for coronavirus treatment. Both give some kind of impact on the disease. In Merck's case, they can halve the number of people who become severely unwell. In the case of Pfizer, they actually found protection at a very high fraction of people who are given this drug. Both are useful once people have developed symptoms. So this is a good way of keeping vulnerable people out of hospital and preventing severe disease. It is a welcome addition to the arsenal of drugs that we currently have to throw at this condition.
Okay, and that's where we have to leave it. Thanks to all of you for being with us. And that's it for this edition of The Heat. I'm Anand Naidu in Washington, D.C. Thanks for watching.